Welcome to Deep Dive Ortho. Think for a moment about the sheer artistry and, well, the engineering marvel that is the human hand.
It really is incredible.
An instrument of incredible precision, isn't it? From tying a suture to complex surgical maneuvers, it lets us interact with the world in so many ways.
Absolutely.
Yet, as you know, in our field, this intricate system is remarkably sensitive. Even the slightest imbalance can profoundly diminish a patient's functional capacity.
Oh, definitely. It leads to significant limitations, both in daily life and sometimes professionally, too.
Exactly. And today we're embarking on a deep dive into a specific, often challenging clinical condition that perfectly embodies this delicate balance, the intrinsic plus hand.
A really important topic.
It is, and this isn't merely a descriptive label, is it? It's a distinct clinical entity with profound implications for hand function. It demands a truly nuanced understanding for effective management.
That's right. You need to get under the skin of it, really.
So, our mission in this deep dive is to equip you, our audience of mid-senior medical professionals, with comprehensive insights. We'll cover its definition, the intricate anatomy involved,
The intrinsic muscles themselves, yes.
the diverse causes, the precise diagnostic approaches we use, and the full spectrum of non-surgical and surgical strategies.
From splinting right through to complex releases.
Our goal is to empower you with essential knowledge to elevate your clinical practice and significantly improve patient outcomes. Let's unravel this.
Indeed. The intrinsic plus hand is a particularly compelling area because it truly highlights how interconnected the hand's components are. A thorough grasp is, well, paramount for anyone involved in hand care.
Because it can be quite subtle sometimes.
Exactly. Its presentation can often mask significant underlying issues.
Absolutely. So let's begin right at the foundation. How do we define the intrinsic plus hand? What are its core characteristics? What should first spring to mind for a clinician?
Okay, so at its core, the intrinsic plus's condition refers to a tightness, or sometimes in more advanced stages, a contracture of the interosseous and lumbrical muscles.
The small muscles within the hand itself.
Precisely. Now, this tightness creates a very specific, almost paradoxical imbalance of forces within the hand. Clinically, what you'll typically observe is hyperflexion at the MCPJs that's bending at the knuckles,
Right.
coupled with hyperextension at the PIPJs, the middle joints of the fingers.
Okay, so flex knuckles, straight, or even backward bending middle joints.
That's the one. This distinctive posture is the hallmark, the immediate visual cue. Flexed MCPs, hyperextended PIPs. That's your first major clue.
And this isn't a new discovery, is it? It has quite a history in hand surgery.
That's a very good point. It goes back a fair way. Its initial description dates back to Finocchio in 1920. He first put it on the map, so to speak.
Right.
But it was Sterling Bunnell, whose aim is, practically synonymous with the foundations of modern hand surgery,
Of course, Bunnell.
who really expanded our understanding in 1946. Bunnell's work gave us a much more comprehensive framework for how we perceive and approach this condition. His contributions were pivotal.
Moving it from just an observation to something we could clinically understand and manage.
Exactly. We still rely heavily on that foundational knowledge today.
So when we talk about tightness versus contracture, are these terms interchangeable, or is there a critical clinical distinction that really changes how we manage it?
Oh, that is a vital distinction. Absolutely vital. It guides every treatment decision you make. Intrinsic tightness describes a less severe, often earlier process.
Okay.
In this state, while there's some deficiency in PIPJ flexion, it remains passively correctable. You can, with a gentle external force, get more flexion.
You can overcome the tightness.
You can. Whereas intrinsic contracture, well, that signifies a more advanced and essentially irreversible state, at least without surgery. Passive correction of the PIPJ flexion deficiency just isn't possible anymore.
Why is that? What's happened structurally?
The tissues have undergone structural changes, often fibrosis. They become rigid, unyielding. So the key insight here is that this distinction isn't just semantics, it's the pivot point for your treatment strategy.
Right.
Fail to differentiate, and you risk either overtreating an early tightness, or maybe worse, undertreating a fixed contracture, potentially locking in a chronic disability. It's the first crucial decision point.
That makes perfect sense. Knowing what's correctable dictates the next steps. But to truly understand why things go wrong, we need to unpack the anatomy of these intrinsic muscles. You mentioned the interosseous and lumbricals. Can you walk us through their mechanics and importance?
Certainly. An intrinsic muscle, by definition, has both its origin and insertion points located entirely within the hand.
Okay, unlike the extrinsics coming from the forearm.
Precisely. Key examples are the narir muscles for the thumb, the hypothenar for the little finger, and, crucially for the discussion, the interossei and the lumbricals. Their contribution is immense, often underestimated.
How significant are we talking in terms of strength and dexterity?
They're absolutely critical. They produce MCP joint flexion, bending the knuckles, and simultaneous IP joint extension, straightening the fingers. This coordinated action is essential for fine motor tasks.
That sounds quite complex.
It is. And functionally, these small muscles contribute roughly 53% of overall grip strength
Wow, over half.
and a remarkable 85% of pinch strength.
85%. That's huge for pinch.
It is, which is why any dysfunction, tightness, or contracture so severely impairs hand capability and, consequently, quality of life. Biomechanically, it's their unique path. Volar to the MCPJ axis for flexion, but dorsal to the IPJ axis for extension. That gives them their unique action.
That is staggering, especially for pinch. Let's break them down individually. Starting with the interossei, how do they contribute to stability and finger movements?
The interossei are, well, the unsung heroes of finger stability and horizontal movement. We have 7, 4 dorsal and 3 palmar. Their primary functions, as mentioned, are MCP flexion and stabilization, plus IPJ extension. Beyond that, they're crucial for horizontal movements, abduction and adduction.
Spreading the fingers and bringing them together.
Exactly. Palmar interossei adduct, bringing fingers towards the middle finger. Dorsal interossei abducts, putting them apart.
Oh.
And a small clinical pearl. Remember, the little finger has its own abductor. The abductor digiti quinti, and the extensor digiti quinti helps too. It doesn't rely solely on a dorsal interosseous for abduction.
Good point. And their anatomical attachments, where do they originate and insert? That must be critical for precise intervention.
Absolutely. Understanding these insertions isn't just for exams. It's vital when planning a targeted release or figuring out which muscle is driving a deformity. They originate from the sides of the metacarpals.
Right.
Their insertion points differ slightly, and these dictate their action. Palmar insert onto the index, ring, and small fingers.
Right.
Dorsal onto the index, middle, and ring fingers. Specifically, the first dorsal goes to the index, second and third to the middle, fourth to the ring.
Okay, quite specific.
It is. And what's clinically interesting is the first dorsal interosseous. It has varied insertions, including the proximal phalanx, extensor mechanism, and volar plate. This versatility explains its key role in power and precision pinch, which is often severely hit in intrinsic plus hands, makes it a critical focus during assessment.
Fascinating. Now, the lumbricals, they're quite unique, aren't they, with their origin and dual innervation?
They certainly are. Their uniqueness is almost entirely down to their anatomical setup, giving them a special biomechanical advantage. 4 lumbricals, dual innervation. The first and second, the radial ones, get the median nerve. The third and fourth, the ulnar ones, get the ulnar nerve.
Okay, so nerve injuries can affect them differently.
Precisely. But what's really peculiar is their origin and insertion. They don't start on bone. They originate from the flexor digitorum profundus, the FDP tendons.
The main finger flexors.
Yes, the flexors. And then they insert onto the dorsal extensor expansion via the lateral band, part of the extensor mechanism.
So they connect the flexor and extensor systems directly.
In essence, yes. This unusual, almost floating arrangement makes them crucial for coordinating the complex interplay between finger flexion and extension. They're a direct mechanical link, allowing that simultaneous MCP flexion and IP extension key for a precise grasp.
That dual innervation and origin insertion really highlights their coordinating role. Okay, we've defined the condition and explored the key anatomy. Let's move to the roots of the problem. What actually causes this intrinsic tightness? What's the underlying pathophysiology?
Right. At a fundamental level, intrinsic tightness or contracture involves a shortening of these interosseous and lumbrical muscles. Now, why they shorten? That can arise from several underlying states. Ischemia, so inadequate blood supply causing muscle damage.
Okay.
The formation of adhesions, those fibrous connections restricting movement, displacement of anatomical structures, altering force vectors, or spasticity, that abnormal increase in muscle tone from neurological injury.
And these states are triggered by...
They can be triggered by a whole range of conditions, which we broadly group as either localized, affecting the hand directly, or systemic, manifesting as part of a wider disease process. Understanding this differential is crucial.
Let's start locally then. How do common injuries like metacarpal or proximal phalanx fractures lead to intrinsic tightness?
Fractures in the hand are definitely a common culprit. For metacarpal fractures, the mechanisms usually involve secondary edema, swelling, prolonged immobilization leading to stiffness, and then the formation of adhesions and fibrosis within the tendons and muscle bellies.
So the muscle itself gets scarred or stuck down.
Exactly. It effectively shortens it, makes it less pliable. With proximal phalanx fractures, it can be even trickier. These can displace the lateral bands, those tendinous slips.
Right.
And callus formation during healing can cause stretching or impingement. Crucially, adhesions can form within the lateral bands themselves, restricting PIP flexion regardless of the MCPJ position.
So even a fracture outside the joint can directly affect movement further down the finger.
Precisely. It explains why even extra-articular proximal phalanx fractures can profoundly impact distal joint movement and are prone to developing intrinsic tightness. A critical point for any orthopedic surgeon: manage that potential tightness proactively.
And what about other localized trauma or inflammation?
Well, severe burns to the hand, direct local infections, or acute compartment syndrome can also directly cause intrinsic tightness. The impact on tissue health, the intense inflammation, subsequent scar formation, it all contributes to shortening and fibrosis.
Compartment syndrome especially sounds dangerous for this.
Extremely. That pressure buildup cuts off blood flow, leading to muscle and nerve damage, often resulting in irreversible contractures. Early recognition and fasciotomy are absolutely paramount there.
Mallet finger is so common. Can that seemingly minor distal injury play a role too? Perhaps leading to bigger problems?
It absolutely can. This is often missed. With mallet finger, the extensor mechanism at the DIP joint is disrupted. This imbalance redirects intrinsic force mainly to the PIP joint, causing hyperextension. Over time, this can progress to a classic swan neck deformity and, critically, intensify intrinsic contracture because the volar plate at the PIP gets chronically stretched and weakened. The altered mechanics gradually cause fixed tightness.
So a distal injury having proximal consequences, that's key. Now, the lumbrical plus finger sounds fascinating, given their unique anatomy. How does that manifest? What's the mechanism behind that paradoxical extension?
The lumbrical plus finger. A fascinating and, frankly, a don't-miss diagnosis. Causes include an FDP injury distal to where the lumbrical originates, a lax tendon graft after repair, distal amputation leading to unopposed pull, or even a high median nerve palsy affecting the FDP.
Okay, several potential trigger.
Yes, and the mechanism is this. The FDP tendon, where the lumbrical starts, retracts proximally due to the injury or laxity. This retraction increases tension on the lumbrical muscle and its insertion into the lateral band.
So it pulls harder on the extensor side.
Exactly. It pulls on the extensor mechanism. The result is paradoxical extension of the PIPJ, or significantly difficult PIPJ flexion. So when your patient tries to flex their finger and it paradoxically extends at the middle joint,
That's the aha moment.
that's it. It tells you the lumbrical is over-tensioned, pulling on the extensor mechanism, a crucial insight needing specific surgical correction.
Truly paradoxical, a great insight for clinicians. Beyond these local issues, what about systemic conditions? Which ones frequently manifest as intrinsic plus hand?
Systemic conditions often reflect wider disease processes. Rheumatoid arthritis, RA, is a prime example. We see intrinsic tightness quite commonly in RA patients.
Why is that an RA?
It typically stems from a combination of things: adhesions, chronic inflammation, even localized hypoxia within the muscles due to microvascular changes. Plus, the progression of RA itself, those characteristic MCP joint dislocations and ulnar deviation, directly contributes by altering hand biomechanics and stressing the intrinsics.
And neurological conditions like spasticity, how do they fit in?
Spasticity, from conditions like cerebral palsy, stroke, tetraplegia, or traumatic brain injuries, is another major systemic cause. The neurological impairment leads to increased, often involuntary, muscle tone.
So sustained muscle contraction.
Exactly. Sustained hypertonicity results in chronic intrinsic tightness, often causing the hand to clench. Importantly, spasticity-induced tightness is frequently associated with other contractures, like in the shoulder and elbow. It points to a wider neurological impact, influencing a multidisciplinary approach.
Is Parkinson's disease also on that list?
Yes, Parkinson's can indeed lead to intrinsic contractures. The characteristic rigidity, bradykinesia, and tremor can contribute over time. Patients might present with a flexed, rigid hand posture that resembles intrinsic plus, although the underlying cause is different.
Right, so we've covered the anatomy and the diverse causes, from local trauma to systemic conditions. Now let's shift to the clinical presentation and, crucially, diagnosis. How does an intrinsic plus hand typically present, and is it always obvious?
Well, it's primarily a clinical diagnosis, meaning meticulous physical examination and patient history are key. adjunctive tests help pinpoint the cause, but astute observation and specific tests are paramount. And again, that vital distinction. Tightness is passively correctable, contracture is not. That difference informs your assessment immediately.
What might patients complain of? What struggles bring them in?
Frequently, they'll complain of difficulty grasping large cylindrical objects. Think holding a water bottle, a large mug, maybe a banister.
Why specifically large objects?
Biomechanically, it's because of that restricted PI-PJ flexion when the MCP joint is extended. In a normal grasp of a large sphere, FDP, FDS, and intrinsics work together, flexing all joints simultaneously for a conforming grip.
Right.
But in Intrinsic Plus, the IPJs might flex before the MCPJs, or there's simply limited PI-PJ flexion with MCPJ extension. They might compensate with a hook fist posture. The flexors might still be strong enough to overcome the tightness for IP flexion, but that coordinated, powerful grasp is lost.
And long-term, if left untreated, what deformities might develop?
If chronic tightness persists, unfortunately, it can evolve into severe, non-correctable contractures. This can lead to specific deformities, most notably the swan neck deformity, indicating significant progression and becoming quite disabling. It moves from a functional limit to a structural deformity.
So a thorough physical exam is vital. What specifics should clinicians focus on?
Absolutely. Beyond initial observation, you need to meticulously check the hand's resting posture, its movement ability active and passive, paying close attention to finger position at rest and during function. Look for any muscle shrinkage or atrophy in the intrinsic compartments, too.
Why atrophy?
That can give crucial clues about underlying nerve issues, like ulnar neuropathy or just chronic disuse. This detailed observation often points you towards the specific muscles affected.
How do we quantitatively assess muscle strength and function to track progress or confirm suspicions?
We use various methods. Comparing muscle power between hands with a dynamometer for grip and a pinch meter is standard. Specific clinical tests, like Froment's sign holding paper between fingers against resistance, can reveal ulnar nerve issues, indicating interosseous weakness.
Right.
Requesting specific finger movements against resistance helps identify extrinsic imbalances. For deeper insight, EMG can assess volitional control, muscle activity, and nerve conduction, especially if neurological causes are suspected.
Let's talk about Bunnell's test, the intrinsic tightness test. It sounds like a cornerstone. Can you walk us through it step by step? What does a positive result mean?
Bunnell's test from Sterling Bunnell back in 1946 is indeed critical for distinguishing intrinsic tightness from other stiffness causes. Here's how you do it. Step 1. Passively extend the patient's MCP joint. This maximally stretches the intrinsics across that joint. While holding that extension, measure the maximum PI-PJ flexion achievable. You're putting them on stretch.
Okay, MCP extended, check PIP flexion.
Step 2. Next, passively flex the MCP joint, usually to about 90 degrees. This relaxes the intrinsics across the MCP joint. With the MCP flexed, measure maximum PI-PJ flexion again.
MCP flexed, check PIP flexion again, and the interpretation.
The key is the comparison. An increase in PI-PJ flexion when the MCPJ is flexed compared to when it was extended strongly suggests isolated intrinsic tightness. Relaxing the tight intrinsics allows more PI-PJ flexion. That's your aha moment for intrinsic tightness.
That's very clear. Can this test be refined to pinpoint specific muscles?
Yes, absolutely. Crucial for surgical planning. You can modify it by putting the MCP joint into radial or ulnar deviation during the test. Radial deviation tightens the ulnar side intrinsics. Ulnar deviation tightens the radial side ones, helps differentiate which side is tighter.
Clutter.
And here's a vital tip to avoid misdiagnosis. If the force needed to flex the IP joints increases when the MCP is flexed, that suggests a contracture of the extrinsic extensors, not the intrinsics. Absolutely crucial distinction for correct treatment.
You also mentioned the volar plate test. How does that help differentiate joint versus muscle issues, especially if inflammation confuses Bunnell's test?
The volar plate test is excellent for isolating the joint. PIP joint inflammation can definitely confound Bunnell's, causing pain or resistance mistaken for intrinsic tightness. So, to isolate it, first, flex the MCP joint to 90 degrees.
Relaxing the intrinsics.
Exactly, eliminating intrinsic spasm as a pain source. Then, while keeping the MCP flexed, passively flex the PIP joint. Any remaining significant resistance or pain during this PIP flexion points strongly to PIP joint inflammation, stretching the capsule, compressing the volar plate. It helps pinpoint if the restriction is muscle, tendon, or joint-based.
The swan neck deformity sounds like a significant progression. How does chronic intrinsic tightness lead to that specific appearance? What are the biomechanics?
It's a classic unfortunate progression. Severe Chronic intrinsic contracture leads to chronic hyperextension of the PIP joint. This hyperextension slackens the terminal extensor tendon at the DIP joint.
So the fingertip troops.
Well, it allows it to flex more easily, and it simultaneously tightens the FDP tendon due to the altered mechanics. The result is compensatory flexion at the DIP joint. So you get hyperextended PIP, flexed DIP, the swan neck.
Right.
Over time, this chronic stress also stretches and weakens the volar plate at the PIP, the structure preventing hyperextension, and contracts the collateral ligaments and capsule, making the deformity rigid.
So while clinical diagnosis is primary, what adjunctive investigations might support findings or delve deeper into the cause, especially for our audience wanting comprehensive understanding?
While it's primarily clinical, we certainly use supplementary tests. Isolated strength and pinch measurements quantify deficits objectively. For rheumatoid patients, X-rays are crucial to assess joint subluxation or damage.
And blood tests.
Rheumatoid serology, definitely, for systemic causes. In spasticity, nerve blocks with local anesthetic before Bunnell's test can be incredibly helpful. They differentiate increased muscle tone, which responds to the block, from fixed structural contractures, which don't.
What about EMG or imaging?
Dynamic EMG gives insights into volitional control and muscle activity, especially in neurological cases. And high-resolution imaging, like ultrasound or MRI, can be invaluable in trauma to identify specific nerve breaks, neuromas, or scar tissue, offering detailed anatomical insight.
Right. Armed with a clear diagnosis, let's turn to treatment. What are the general principles guiding management? How do you tailor the approach?
The primary goal is always to prevent irreversible contractures or their progression and restore as much function as possible. The chosen pathway is highly individualized. It depends meticulously on the underlying cause. The severity, tightness versus fixed contracture is paramount here, and critically, which specific joint or joints are involved. PIPJ only, or both PIPJ and MCPJ. This guides everything.
And before jumping to surgery, non-surgical management must play a key role. What are the foundational interventions?
Oh, absolutely. Non-surgical treatment is foundational and should be pursued diligently until no further progress is seen, or if it's still just tightness. Simple things first. Elevation to reduce edema, swelling, protein deposition, and scar formation.
And splinting.
A key intervention is splinting in the intrinsic plus position, sometimes called the Edinburgh position or safe position splint. It's very precise. Neutral wrist or slight extension, up to 15 degrees, MCPJs flex to 90 degrees, and PIPJs in full extension.
That specific position, what's the biomechanical rationale? Why is it safe?
The rationale is sound. MCP flexion to 90 degrees maintains maximal length of the collateral ligaments, preventing scar contraction that leads to stiffness and extension. Keeping the PIPJs extended preserves the volar plate length there, preventing flexion contractures.
So it prevents the common deformities?
Exactly. This safe position, or anti-deformity splint, is remarkably effective. It's easy to apply, often reduces the need for intensive hand therapy initially, allows immediate active finger flexion, and helps control pain and edema. A critical early intervention.
In which specific clinical context is this splint most used, beyond general post-op care?
Broad applications, often in the first post-op phase to support fixation, or in the first week if there's significant swelling. Crucially indicated for burns to the back of the hand, where extensors can pull the hand into an intrinsic minus posture. This splint prevents that.
Ah, interesting.
Also vital for stroke patients starting to develop contractures, and in low ulnar and median nerve injuries to prevent secondary deformities. Practically, always pad bony prominences, separate fingers with gauze. Sometimes buddy strapping helps too.
Beyond splinting, what other non-surgical approaches involve active patient participation?
Manual stretching is very important, requires consistent patient effort. Techniques include passive finger abduction or passively extending the MCPJ while flexing the IPJs. Patients need specific exercises.
And other types of splints.
Progressive static splints or serocasting can be used. These hold the MCPs in extension, facilitating passive hook exercises, basically doing the intrinsic tightness test, actively, gradually increasing range over time.
What about injections, like Botox?
For patients with increased intrinsic tone, especially from spasticity, but who still have good volitional control, Botox or phenol injections can be a valuable trial. They temporarily reduce tone, approximating the effect of surgery, allowing better assessment and potentially delaying or avoiding surgery by making rehab more effective. A key diagnostic and therapeutic tool.
Right, so once non-surgical options are exhausted or for fixed contractures, we turn to surgery. How do we choose among the diverse options given the complexity?
Surgical options are diverse, not interchangeable. The decision hinges heavily on the exact cause, the severity mild tightness versus severe fixed contracture, and crucially, the specific joints involved. PIPJ only, or both. Procedures range from releases to muscle slides or tendon translocations. Patient goals also matter significantly.
Let's start with PIPJ issues. What is a distal intrinsic release and when is it indicated?
The distal intrinsic release is mainly for milder cases, difficulty making a full fist, grip weakness, aiming to improve PIPJ motion specifically. Its purpose is decreasing intrinsic force on the PIPJ without compromising MCPJ flexion.
So it won't help if the MCP joint is also contracted.
Exactly. If significant MCP flexion contractures exist, it's inadequate alone. The technique involves resecting the ulnar and/or radial lateral bands and oblique fibers in the distal third of the proximal phalanx. Crucially, the release must be distal to the transverse fibers responsible for MCPJ flexion.
And if that's not enough?
You progressively release more volar and proximal tissue guided by intraoperative assessment until passive PIPJ flexion is satisfactory.
What about addressing MCPJ flexion contractures? What are the surgical approaches there?
For MCP flexion contractures from intrinsic tightness, options depend on severity and cause. We consider proximal intrinsic release, PIR, interosseous muscle slide or fractional lengthening, or even ulnar nerve motor branch neurectomy, each for different scenarios.
Let's take the proximal intrinsic release, PIR. When is that used and what does it involve?
PIR is indicated for significant MCPJ flexion contracture due to fibrotic intrinsics, where no muscle function recovery is expected. Think severe, chronic cases. The technique involves dividing the interosseous tendons proximal to the MCPJ.
Okay.
Critically, you identify and preserve the sagittal hood fibers of the extensor mechanism, but release the transverse and oblique intrinsic fibers proximal to the MCP joint. The major implication? This results in loss of the primary MCPJ flexors. The patient won't actively flex their knuckles post-op. Needs careful consideration and discussion.
And for cases where some intrinsic function remains, maybe in ischemic or spastic conditions, and you want to preserve it,
Then the interosseous muscle slide or fractional lengthening are preferred. They aim to lengthen the muscle tendon unit without completely sacrificing it. The slide involves elevating the interosseous origins from the metacarpals.
lifting the muscle off the bone.
Yes, sometimes including the first dorsal interosseous. Then you splint the MCPs in full extension, allowing the origin to heal more distally, effectively lengthening the unit. Fractional lengthening is an alternative, an oblique cut in the tendon part of the myotendinous junction, preserving muscle fibers, achieving length while keeping some function.
You mentioned ulnar nerve motor branch neurectomy. When is that drastic step considered? What are the implications?
Ulnar nerve motor branch neurectomy is really for specific cases. Spastic patients with severe intrinsic tightness, but no volitional control of those muscles. You excise the ulnar nerve's motor branch in Guénon's canal.
Does that knock out all intrinsics?
Not entirely. It usually preserves some activity in the index and middle tubercles due to their dual median ulnar innervation, an important consideration in severe spasticity. Extrinsic tightness can mask intrinsic tightness. So after an extrinsic release, if the MCP passively extends, neurectomy can prevent further intrinsic contracture. If not, a tenotomy near the MCP might be needed too. It can be multi-layered.
So if chronic tightness progresses to that specific swan neck deformity, what corrective procedures are available?
For swan neck deformity with volar plate laxity, we have targeted procedures. Intrinsic tenodesis is one, indicated specifically for swan neck from chronic PIPJ hyperextension. You do a distal release of the tighter intrinsic muscle. Then reroute the contralateral intrinsic tendon beneath Cleland's ligament to counteract hyperextension, securing it to the proximal phalanx after tenotomizing its proximal third.
Rerouting a tendon to act as a check crane.
Essentially, yes. An alternative, if Cleland's ligament seems weak, is a lateral band translocation. Divide Cleland's, find the volar plate flexor sheath, make a dorsal flap, translocate the lateral band volarly, and reposition the flap to prevent hyperextension.
And for more rigid swan neck deformities?
For those, lateral band mobilization is employed, usually a dorsal incision for extensor tenolysis, dorsal capsulectomy, and mobilizing the lateral bands by releasing them from the central slip and triangular ligament. Frees up the tight structures contributing to rigidity.
Finally, for that paradoxical lumbrical plus finger, what's the targeted surgery?
For lumbrical plus, it's a radial lateral band resection. You transect the radial lateral band either at its origin in the palm or its insertion into the dorsal apparatus. The aim is to stop that paradoxical PIP extension, allowing normal coordinated flexion.
That's a comprehensive tour of treatment options. To wrap up, let's consider the broader picture. differential diagnosis, prognosis, complications, and prevention. Professor, when evaluating for intrinsic hand issues, what else must we rule out?
Absolutely crucial to cast a wide net. Rule out high ulnar nerve injuries, anterior interosseous nerve AIN compression, Parsonage-Turner syndrome, brachial plexus neuritis,
Nerve issues mostly.
often, yes, but also carpal tunnel syndrome, the most common entrapment pronator syndrome,
Yeah.
and beyond nerves. Volkmann's contracture, that ischemic forearm stiffness, and Dupuytren's contracture, the fibrotic condition causing finger flexion, especially ring and little fingers, can mimic intrinsic problems.
Are there anatomical quirks that can confuse things?
Yes, indeed. Being aware is key. The Martin-Gruber anastomosis, that AIN to ulnar nerve connection, in about 15% of people can mean partial function remains, despite a confirmed complete proximal ulnar injury. Changes how you interpret findings.
Looking long-term, what's the prognosis? What can patients realistically expect after intervention?
Prognosis varies. Younger patients generally do better, especially regaining fine motor control. Less severe injuries, nerve lacerations fixed early, have better outcomes than chronic cases.
And worse prognosis for?
Older patients, severe or long-standing injuries, chronic ulnar neuropathy, especially with muscle wasting, they face a tougher path, often with residual deficits. Importantly, convey that treatment offers relief, but significant improvement can take a long time, maybe up to 5 years post-surgery, for maximal recovery.
But some procedures offer good improvement.
Oh yes. For claw hand deformity, surgeries preventing MCP hyperextension significantly improve outcomes and function. Managing expectations in stressing rehab is key.
What are the potential complications if intrinsic tightness or a mild deformity is left untreated?
Several debilitating issues. Progressive loss of MCP joint extension fingers can't fully straighten. The characteristic swan neck deformity can develop. And a mild claw hand can worsen to involve all fingers, profoundly impacting function and quality of life. Underscores the need for early, accurate diagnosis.
Finally, what role does patient education play? How can we help prevent these deformities or mitigate progression?
Patient education is absolutely critical, cannot be overstated. Empowering patients to understand their condition, their treatment options, the vital importance of compliance with therapy and post-op instructions, it significantly improves quality of life.
Making them active participants.
Exactly. Explaining the why behind stretches, splinting, warning signs, it makes all the difference. It helps prevent serious complications and progression. It's arguably one of our most powerful tools.
Professor, this has been an incredibly thorough deep dive into the intrinsic plus hand. From its subtle origins and diverse causes to diagnostic challenges and the array of treatments. The impact of this knowledge on clinical practice enhancing diagnosis, management, and patient outcomes is abundantly clear.
It's a complex but rewarding area to understand well.
If you found this deep dive valuable, please consider rating and sharing Deep Dive Ortho with your colleagues. As we continue to refine our understanding and techniques, consider how emerging technologies, advanced diagnostics, maybe biomechanical modeling, even regenerative medicine might further revolutionize our approach to these complex deformities in the coming decade. What will the next Bunnell's test look like, I wonder?